welcome to the ORTHO REAL Podcast. Our guest today is another luminary in the space of orthopedic joint replacement, Dr. Hugh Cameron. Extensively published on joint replacement surgery, has been involved in teaching about it internationally, all over the world during his career, and has been really one of the pioneers in joint replacement surgery. Author of multiple books, countless articles. Dr. Cameron, thank you for joining us.
Well, thank you for asking me.
Can you tell us a little bit about how you got into medicine and subsequently orthopedics? I know you started off in Scotland and your journey to North America and what all transpired there.
Yeah, well, it's kind of funny. I thought I was going to the Olympic Games as a hammer thrower. This was before anabolic steroids, and then I ran into problems with my... So I was looking for some course at university, which was a long, slow course, and medicine in Scotland is a 6-year program. And what I really wanted to do was engineering, but medicine was second best, and that the engineering program's intense, the medical program's not so intense. So I ended up doing medicine, which I actually liked. And the reason I got into orthopaedics was in Scotland, we used to do a lot of work in the hospitals. When the residents were on holiday, the medical students would fill in. And the guys I liked best were the orthopedic surgeons. And so I ended up wanting to do that. And it was one of my professors who was fairly well known in the US because he'd worked with the Department of Veteran Affairs and Amputations. He was the one who suggested that it was time to leave Britain because Britain was in a terrible mess at that time. And he suggested that I go either to Kay Clausen in Seattle or Gus Sarmiento in Florida or Toronto. Now, Gus Sarmiento I sort of knew and liked, but Gus said as soon as you go to the US, this was in the early 70s, they'll draft you and send you to Vietnam. So I thought, maybe I'm not keen on that. So I went to Toronto. And the year before I went, because I knew I had to wait a year to get in, I did engineering. I did bioengineering because orthopedics, after all, really is just applied engineering. And that has been enormously useful. It's not that I need to know the Laplace transform, but I need to know who knows the Laplace transform, and I need to know the significance of it. So that year I spent in doing bioengineering in Glasgow was enormously useful. And then I came to Toronto in 1972, and of course the Toronto program at that time was absolutely wonderful. I ended up working for Ian McNabb. And I got lucky when I came because he had known an engineer who was thinking about bone ingrowth into implants. So I did all the animal work for that, and that was with an engineer called Bob Pillier. And so Bob Pillier and I did all the basic science involving ingrowth. At that time, there was only 2 other people in the world working on it. George Galante in Chicago was, and Brannemark, the dentist, was working in it in Sweden. So it was a completely new field. And it took about 10 years probably. No, it wasn't that. Certainly about 5 or 6 years before we had done enough of the basic work that we could think about doing implants. And so I did the first porous coated implant. I put it in Toronto General when I went on staff there in about 1976 or 77. And since then, of course, porous coating is now the almost universal method of anchoring hips, and a lot of knees are also done with porous coating.
Absolutely. You really were in a transition point where everything with the hip had been, most everything had been cemented to that point. So that was a transition point. So stepping away from the history for a minute, do you see that coming into increasing use in knees? Are we going to be at all cementless knees at some point?
Oh, yes. I've done nothing. Well, not nothing, because the guys who were interested in the cruciate substituting knees, Chet Ranawat and John Insall, they were not interested in porous coating. They were happy with cement. So there was the two schools, the cruciate retaining guys like Leo Whiteside and myself and Tony Headley, we were interested in porous coating, whereas the cruciate substituting guys wanted to use cement. I had one of the earliest porous coated knees in the market. It was Tricon I did with Richards, again in the early 80s. And I never had a loose femoral component because it was an opening wedge, so that if you stood on it, it wedged it on tighter. So I think that for certainly a cruciate retaining type knee, there's absolutely no need of cement, unless you have problems, of course, if it's a revision or if there's some issues with the bone. But for a primary knee, I see no reason that all femoral components should not be cementless. The tibial component, there was a lot early ones on the market. For example, the early PCA that I know Tony Headley was working with, their femoral component was good, the tibial component was not. The fixation was inadequate. We knew from some of the work I had done what movement was allowable. If you have too much movement at the bone implant interface, the bone won't grow in. It has to be very, very limited, which means the implant's got to be tightly anchored to the bone for the first 6 weeks to allow bone ingrowth. But I don't see that as a problem. I mean, we have now numerous designs. I used the Tricon and then Profix, which I did with Leo Whiteside, and also one of the Sigma knee, which I did with Johnson & Johnson. These were all non-cemented, and they all worked just fine, both femur and tibia.
Well, you touched on a great point there. You've been involved in a lot of design work. A lot of implants sort of have your fingerprints, if you will, all over them. I believe you were very intimately involved in the development of the SROM stem as well, which is, 30 plus years now of a great track record and still a very commonly used implant system. Not many have stayed around that long.
Yeah, that was funny. It was the SROM was originally Sivash. It was originally a Russian hip. Now, Sivash was enormously clever. He had several things which no one ever thought of. He was the first titanium stem with a cobalt chrome head. He was the first guy to think of a sleeve, and he put some slots on the stem to reduce the bending stiffness. Now, these were, I thought, breakthrough ideas. Now, none of them worked because the design wasn't any good. But all you need is the concept. You can always make things work.
Right.
So I came on board when a friend of mine who I've known for years, Tim McTighe, he was the salesman he was the product manager for knees for Richards or Smith & Nephew, as it is now, when I started working with them on knees. And then when he moved to this other little company who had the Sivash stem, he phoned me and said, this doesn't work. Can you make it work? So there were some really good engineers there that I thoroughly enjoyed working with. And it took us about a year to tweak it and to make it that it worked. And basically the stem hasn't changed in 30 years. And it's still in use today.
Absolutely, it is. Is that what's your proudest point as far as what you've developed? Do you have a favorite child, so to speak, of the implants you've been involved in?
I like the knees, but I really like the SROM stem because there wasn't anything we couldn't handle with it. I mean, I did a lot of work in Japan, and for them, we actually took the SROM down to a 6mm stem, if you can believe it. Because the older Japanese were tiny. They're not now, they're just the same size as everybody else. I think we sold about 6mm stems. I mean, that's the size of your pencil. And none of them broke, which was pretty good. And at the other end, we could handle anything up to 25 or 24 millimeters internal diameter. But with those, I realized that was just too big. So what I started to do for these huge canals was I did narrowing osteotomies. If you go with a long stem, that resolves the end of stem pain. But if you want to use a regular stem, I began to do an osteotomy where I could actually close it down around the stem, so I could reduce the internal canal diameter from 25 down to about 21. And if you use a 21 millimeter stem, there's no problem with end stem pain. Whereas if you use a 24 millimeter stem, they're all going to get end stem pain because the implant's just so stiff no matter what you do with it. Mm. And I use the SROM stem all over the world. I mean, I used it in China, I used it, so I had great fun with that.
Totally agree, and it's an implant probably used in most all of our ORs all around the world still, and as you said, handles a variety of situations. Certainly, if you were going to hang your hat on one, that would be a good one to do so on. When I think about joint replacement and sort of the community or the space of it, you know, I've been in practice about a dozen years now after my fellowship, and you know, I kind of look around at a lot of these folks that have been very influential, and you know, in the past year, our community, if you will, has lost Dr. Larry Dorr, Dr. Les Borden, certainly my mentor, Tony Headley, and so we're you know, we're losing some of our pioneers, and we're losing some of the knowledge from that era. That's, you know, fascinating to me and probably to a lot of our listeners. I just had the pleasure of reading your book, Have Knife, Will Travel. I know you're doing a lot of writing now, and a lot of that dealt with a particular era of what you referred to as the traveling road show. Can you tell everybody about that?
Yeah, well, this was when we developed knees and hips that actually worked. Before the early 70s, the knee replacements didn't. You know, Frank Gunson's knee and the geometric from the Mayo Clinic, they worked, but they didn't really work very well. And it was really Mike Freeman who developed the sort of cruciate retaining knee, and John Insel and Chet Ranawat who developed the cruciate substituting knee. And so all of a sudden we had knees that worked. Nobody knew how to do it. I mean, there was a few people in Europe and a few in the US. You could almost name them. And it was the same with hip surgery. I mean, I went to see the guys I thought were the greatest surgeons in Europe. There were only about 4 or 5 of them. I mean, there was Robert Judet, of course, the fabulous French surgeon, Renato Bombelli in Italy, and a few more like that. And of course, the greatest surgeon in all the world, I thought, was Heinz Wagner. I mean, that was like watching God operate. I mean, he was just unbelievable. But so we had developed these knees and hips, but no one outside the US, even mostly inside the US, knew how to do it. When we started teaching, the average surgeon in the US was doing less than 10 joints a year. Wow. Now, at that level, you can't be any good. I mean, you just don't, with all the best will in the world. Sure. So we spent an awful lot of time on instruments to try to help them, and then to teach them how to do it. So initially, the teaching was mostly inside the US, and most of us, there was maybe about 20 of us, you know, Larry Dorr and Tony Headley and, you know, Leo Whiteside and Fred Bickle. And we were on the road about once every couple of weeks. I mean, when we started to sell the SROM stem, what we did was we had a couple of scrub nurses. We got one of John Brothers' scrub nurses and the scrub nurse from one other surgeon. And they covered half of America, so that one girl handled the East Coast and one girl handled the West Coast. And if anybody wanted to do an SROM stem who hadn't done it before, the scrub nurse scrubbed in, because you couldn't have salesmen scrub in, but you can have scrub nurses scrub in. And so that was how we taught in America. Europe, of course, was also pretty sophisticated. But then the Far East began to open up, and because these things are expensive. And so Japan had the money and South Korea had the money. So I was in Japan once a year for 20 years, and the same in South Korea. And gradually other countries, I mean, China was about 30 years behind. So we had great fun. And there was, as I say, there's about 20 of us, and you run into each other on the road. or in the Shilla Hotel was one of the favorite places in Korea. And we also had this, anytime you're in the Far East, the best way to come back is via Japan, because the flights from Tokyo really do very well coming in, time-wise, coming into North America. And in the airport lounge in Narita, they had computer jacks. Most airports at that time didn't have computer jacks. So, I mean, I used to travel with 2 batteries for my computer. So, again, you'd run into all the guys in Narita Airport waiting for their flight to go somewhere. So it was great fun.
Well, and from your book too, I mean, pretty rapid turnaround. I think you indicated that you kind of had a timing schedule with your short acting and long acting sleeping pill of when you got on the flight, so you'd turn around a long trip over a weekend.
Yeah, we were on the road so much, everybody got to know what to do. For flights to Europe, which are about 6 hours from Toronto, I used a short-acting sleeping pill called Halcyon. Now, the problem with Halcyon is that you tend to lose your memory. Because I knew I was...
That could be problematic if you're teaching.
Yeah, but it's short-term.
Okay.
I was once lecturing in Brussels, and so I knew I flew into Charles de Gaulle. I changed terminals in Charles de Gaulle and got another Sabina flight to Brussels. I can't remember being in Charles de Gaulle, but I don't care. I've been there before. For the long flights, we used another long acting one. I got to the stage I could go to Australia for the day, and the way you do that is you fly into LA and you catch the flight about midnight from LA to Sydney, and then you get on the plane, you have a couple of drinks, you pop a long acting sleeping pill and fall asleep. And you're waking up coming into Sydney at midnight. So you take another sleeping pill, you sleep that night, then you give your 3 talks the next morning and catch the same flight back to the US that afternoon.
Wow. Definitely a different era, but a good point, of how do you scale up the educational process for these implants and these systems when people haven't been trained on it. And, I mean...
Yeah, this is something I'm actually very proud of. This was started by Maurice Mueller and the AO group, because before then, all the teaching was university, and it depended on the professor. He told people what to do, so the teaching was terribly haphazard, and it really was very, very poor quality. The Maurice Mueller and the Swiss guys, to sell their AO equipment, they started to run courses in Bern. And then they took the show on the road, and they began to teach worldwide. They completely ignored the universities. And so when we began to sell implants, we followed and there was only about 5 companies, so that's why there's only about 20 surgeons. We followed Maurice Mueller's technique of teaching, that we would go to the country, and the companies would organise courses within the country. If a university wanted to get involved, that was fine. If they didn't want to get involved, that was fine too. So we completely changed what was university teaching. We took it completely outside the university sphere in that sense. And now all surgical teaching is done that way. Before then, you had to go to a university and be nice to the professor and all the rest of it. And that really hadn't changed since the Middle Ages.
Sure. Well, and we've had, I guess, another shift now with just the resources and the content that are available online, of being able to watch in video of people watching, or of people performing surgery from anywhere in the world. And
exactly. Now it's a sea change. I mean, when I was on the road, we were using slides. We had big carousels of slides that we took around with us. There was no computers, there was no Zoom, there was nothing like that. It was only just as in the last 10 years or so that began to use computers. But before then, it was slides that you put into a carousel and put up on a screen. And that was why somebody personally had to be there to do the operations. I mean, I used to get, for example, a course for Japanese surgeons that are around once a year in Toronto. And we get about 30 surgeons over from Japan. And I would operate, and we would pipe it up to the auditorium. And Jim Bono used to come up from New England Baptist to sort of run the meeting for me. And, and those things gradually developed. And as you say now, there's really no need for it because you can tap into that stuff anywhere in the world. You can watch a great surgeon operate.
Well, and there's certainly a great benefit to being live and in somebody's OR and able to really exchange that information. I had a talk with another surgeon here in the U.S. recently who has been very intentional 3-4 times a year. Just whenever he's somewhere, he goes and he finds the great guy in that area and gets in his OR and learn something from him. And it's something that I've tried to do a little bit and I think is also a benefit. But you're exactly right. I mean, the technology has enabled a lot of that. And now we're stepping into a world where virtual reality, augmented reality, and some of these other tools are going to be involved in training residents and training surgeons in technical aspects.
Exactly. But I think you're right. The personal contact makes a big difference. The first time I visited Heinz Wagner, I was in love with his surgical technique. He wouldn't tell you anything very much. But fortunately, when the first time I was there with him, Renato Bombelli was there. And Bombelli knew the complications. And he would say, well, ask him what to do when the hip dislocates. And if you asked him, he would tell you. If you didn't know, he wouldn't tell you. So I think the personal touch really does matter because people will tell you things that they think. I've always called them whispers in the wind. For example, when metal implants got into trouble, I had been in Germany with the fellow who was the professor, Hans Willert, the professor in Göttingen, because I had known him for 20 years. I knew him when he was still in Frankfurt. In fact, I went up to Göttingen with him the first time he went up with the professor there. He told me that he thought there was a problem with metal. He didn't know what it was. And then a couple of months later, I was in Korea, and Yun-Soo Park, who was actually one of my fellows, and he's an absolutely great technical surgeon. He told me there's a problem. And again, they didn't know what the problem was. So at that time, I had been using metal. I did about 150 of them, and I never had any problems. But then I only used a 28 millimeter head. And but I stopped. As soon as two really clever guys in the world tell you there's a problem, I think you should stop until there was nothing they could publish. It was just they had a feeling something was wrong. And so I got lucky. I stopped. Eventually we found out what the problem was. It was nothing to do with the metal bearing. It was the head size. That if you go up to a 36 head size, that you overstress the taper. So it wasn't a bearing surface, it was a taper junction problem. But the problem is that in medicine, if something goes wrong, rather than analyze it, they tend to throw out the baby with the bathwater. I think they should go back to metal, but just nothing bigger than a 32 head. And if you stay with a 28 head, it's fine, there's no problem. But it's like so many of these things, once it gets a bad reputation, no one's going to use it.
I think that's a great point, and maybe that sort of cross-references with what you've talked about, where a lot of this teaching and a lot of this training has quite honestly been facilitated by involvement of industry, and they've got commercial interest here. And so I think a lot of times if there's a potential problem that you or I might hear that whisper in the wind, our immediate reaction, yours was in that case, is to shut it down and just wait and watch and see what's going on. Whereas maybe a more corporate reaction is just to deny it. And then if and when there's a problem that becomes undeniable, then as you said, the baby goes out with the bathwater and everyone's so afraid of litigation that they just don't want to get near it anymore. Yes,
I had that thing with that. I was using a double taper stem for a while, and I hadn't had any problems with it because I was just using it as a cemented stem, so they were just elderly people, and I really had no problem. But Dickie Jones, the Texas surgeon,
sure.
Dickie had been putting them into younger people, and he had a rodeo rider who was wrestling a bull, and while he wrestled the bull, the taper of the neck and stem broke. And we thought, oh, well, it's just Dickie putting it into some bull wrestler or something. But then it happened again. And then I had one patient in which it popped out. And we realized then we have problems. So we immediately closed that down. We stopped using it. And we analyzed the problem, and we increased the length of the taper. We almost doubled the taper length, and we doubled the strength. And 6 months later, we put it back on the market. And since then, we've had no problems with the double taper stem. But so I thought I liked the company because as soon as Dickie and I said, hey, we get problems here, the company stopped. I mean, there was no ifs or buts or we'll cover it up. They just completely stopped. So there never was any lawsuits about those cases. It's not like, some of the companies carried on when they knew there was problems. And because I've been involved in a lot of these lawsuits because I like going to court. And I'm quite happy to be an expert witness. I've done it all my life. I mean, being cross-examined is great fun. You really have to think on your feet. A equals B, B equals C, so C equals Z. Well, not quite. So I was very proud of the company. They just completely closed it down until we'd solved the problem.
Well, you've talked about a lot of things here with implants and some successes and failures, and you've been at this long enough to have a lot of perspective. As you kind of look back through how this industry and some of these implants and ideas go in cycles, you have any thoughts on things that you thought were really good that would be game changers that never really made it, or things that you saw it and were like, man, this is just a garbage idea, but it kind of hung around and actually worked out?
I'll tell you one interesting thing I did. It must be in the late 70s. I had a bunch of kids. They're not really kids. It's mostly a middle-aged ladies' problem. Their feet go flat. And the middle-aged ladies, they rupture tib post and their foot collapses. But I had a bunch of younger kids whose tib post stretched out a bit, and I could shorten that, which was okay. But what I did in some of these kids was, rather than do a fusion, a Grice procedure to push the heel round, I had a little implant made up that I put in the sinus tarsi. It was a metal ball with a little plastic. And I put it in the sinus tarsi so I could wedge the heel round into the neutral position. And I did about 20 of those. One of them was a professional skater who did these big, jumps that these professional athletes do. He did these big jumps in my little piece of plastic. Now, I got too busy with other things and never really pursued that. But that certainly is one thing which would be quite useful, because I don't like fusions. A Grice procedure leaves the hind foot so stiff, it throws strain on the ankle. And 25, 30 years later, the ankle's going to wear out. So that I sort of liked that. And I sort of felt I should have pursued that further, but I never did. I had too much else going on. We were still doing a lot of work with the porous coating implants. As far as other stems are concerned, the resurfacing of the hip. I did the original ones of those. Again, there was 3 people in the world doing it. Mike Freeman in London when I was working with him, Harlan Amstutz in LA, and Heinz Wagner in Germany. And they weren't good. And the reason they weren't good was that we had to use too thick bits of plastic. Now, I got DePuy to make me a piece of plastic that wasn't a hemisphere. It was just a third of a hemisphere. So I could use it a lot thicker. So my results with the hip resurfacing were better than most people. But it wasn't worth it. It wasn't as good as we thought it would be. The reason we resurfaced hips was the stems were coming loose, the cemented stems. And it was a terrible job to revise them. But now stems don't come loose. I haven't seen a loose S-ROM stem in 20 years. And all the other stems, the Tom Mallory stem, the Mallory head, the loosening rate for that's just about 0. So the necessity to stay out of the canal went away. And the big advantage of a stem component is you can, of course, vary the offset, which you cannot do with the resurfacing. So I think resurfacing was a nice concept, and it comes back every 10 or 20 years, and I really don't think it's worth it. I think that the stems are now so good that there's no need for that.
I would certainly agree with you on that point, and it is interesting, as you say, it's in cycles. Again, you mentioned Dr. Amstutz in UCLA. Dr. Headley was on faculty there for a while after his fellowship,
Yes.
and I think Tony had done about 300 of the Theres resurfacing procedures, and he said it was the most universally perfect series of cases that he had done, that they all failed. So when the metal resurfacing came about again in sort of early mid 2000s, he said, "No thanks, guys. I've seen this before." And
yes, and he was lucky not doing it, because they ran into problems with the fixation of the acetabular component, and they were really bad. Well, I shouldn't say that. There's still losses going on. But it was, shall we say, unfortunately not as good as it might have been. Yeah, I knew Tony at that stage. I was a cross-appointed at the engineering department in Waterloo, which is a really good engineering school in Canada. And one of the guys I worked with there, Greg McNeese, he came down to work with Harlan Amstutz. He took a year's sabbatical. And he and Tom Gruen and Harlan were the guys who developed the loosening they classified loosening of cemented femoral components into a very, very useful system, which we could use. So I go back a long way with that too.
So sort of putting on your prognosticator hat, what do we need to be figuring out in joint replacement? What are the frontiers for us? What can we do and get better at?
Certainly upper limb. Upper limb is not good. That's for sure. And ankles are not good. Hips, I think, are really quite good. We still have the problem of revision of the acetabulum. That I would like to see. I'd like to see much better artificial bone graft. Because when you use allograft, that seems to me such, medieval. I worked with Tom Driscoll, it must be in the 80s, on artificial bone graft substitutes. And I've always liked that, because, taking bits out of someone else and putting it into someone else seems to me medieval. So I think there's a lot of work needs to be done on artificial bone graft, and a lot of work needs to be done on bone regeneration. Not so much for the femoral canal, that's not a problem, as for the acetabulum. For the knee, it's pretty good. There are problems though, and the unsolved problem I see for the knee is when the flexion space is too big. Once your flexion space gets over 3 or 4 centimeters, you're really looking at fixed axis hinge. And one of the problems with the fixed axis hinge nowadays is they've all gone rotating, and that's a major mistake. Because one of the problems that there aren't that many knees that fail repeatedly. And the ones that fail repeatedly, it's nearly always due to malpatellar tracking. And if you use a rotating platform hinge with malpatellar tracking, it's going to dislocate. So for those problems, it must be fixed axis, non-rotating hinge. And right now there's only one available from Germany. It's really not a very good one. So I think the industry's got to waken up to the fact that we need better quality hinges. And again, you can make a stem that won't come loose, but you can't make a bearing and a hinge that won't wear out, because the loads on it are too high. So what I would like is stems that you could take the bearing surface out, leaving the stem behind, and just lock in a new bearing surface. But that's the biggest problem I see right now in terms of knee revision, is that there are no good non-rotating hinges.
On the hip side of that, are there a lot or even enough people working on that? Because I feel like with additives manufacturing and 3D printing, you're getting probably more interest in filling all those voids with customized metal pieces rather than something biologic.
Exactly. And if you can do it, that's fine. But often you end up with a $10,000 paperweight because it doesn't quite fit exactly. It doesn't fit as well as you would like.
And what I would like is, you see these wear debris cysts approaching. Now, if you could simply drill a hole in the bone, wash it out with a high pressure washer jet, and inject a bone graft substitute, which we know preferably something that's got regenerative capacity, which would fill the cyst in, then that would obviate the need for a lot of that stuff. Because you can see wear debris cysts, especially in the greater trochanter, long before the patient has any symptoms. And it would be a 5-minute operation, to drill a hole through the top of the trach, wash the debris out, and fill it with a bone graft substitute. So I would see that as like, changing the oil, you change the oil in your car every 10,000 kilometers or something. Well, not me, I usually forget, but it lasts longer. But you can see these problems coming, and some of them are soluble without going to major revisions and without going to custom implants. And yes, being able to print implants certainly is very useful. But we'd like to not. The problem is, the bigger the chunk of metal, the more risk there is of infection, because the bug can snuggle up around the metal and, like a sama hiding in his cave. So I like to use a small, to debulk the metal. I'd rather have the bone regenerate. For example, when I was doing knee revisions for infection, what I would do is I would take the implant out, take off the stems and all the bells and whistles, and then I would fill up all the defects in the bone graft substitute doped with antibiotics, and I would cement what was left, just the two surfaces, back in place as a temporary prosthesis, and then leave it for a year or two if the patient was walking on it. So when you came back to revise that again, the bone had reconstituted itself. So you couldn't use primary components, but you certainly could use a very much smaller revision components than you otherwise would have had to use.
So sort of an impaction grafting type technique with antibiotics in the bone graft.
Exactly, and the bone graft. In Japan they use hydroxyapatite, which is not good, because it takes a century to absorb. You need something that absorbs a lot faster than that. And I prefer tricalcium phosphate, because I thought that lasted about 9 months, which was pretty good. But there's all sorts of potential there, and I can see that as something very useful. Something that you can inject into the bone without having to take the implant apart. Because you can see an implant beginning to loosen up. You can see the wear debris cyst developing long before you need to do anything about it, before the patient has any symptoms.
Agreed. You've stepped away from the OR and doing other things now and writing a lot. Can you tell all of us what you're doing and about some of your books and about some of what you're passionate about these days?
Yeah, what I do now is I have clinics, because 90% of orthopedics don't need surgery, but someone's got to sort out the patient. There's no point in a patient coming to see a surgeon and they haven't decided if they need a knee replacement yet. That's wasting the surgeon's time. That's, I regard, as my function, to come and talk to me, and I can tell you what it will do and what it won't do. And once you've made up your mind to have the operation, then I can send you to see the surgeon. So I do a lot of that. Plus, you got shoulders and wrists, the Quervain's disease, and all that sort of thing, which needs treatment, and it needs treatment by an orthopedic surgeon, but it doesn't need surgery. So I run clinics about 4 to 5 days a week doing that. Not full time, but for 5-6 hours at a time, and I find that great fun. What I'm interested in right now is scoliosis, because I'm very unimpressed about what they're doing with scoliosis. And I see, Toronto's an immigrant city, so I see all these kids coming in from all over the world with essentially untreated scoliosis. And I'm very unhappy with what's being done about it. So I'm thinking about that right now. It's funny, it's an engineer I worked with. She works in the US, and then she married someone to come up to Canada. And so I've known Lida for 30 years. Her kid got scoliosis, So she was interested in it, and she's developed some very interesting stuff. So we're sort of thinking about that. The other thing that I do is I now write. I've always written technical. I mean, I wrote 2 technical books, and I've written, I don't know, at least a couple of hundred peer-reviewed papers. And I've just finished writing a book chapter for one of my fellows who's been writing a book on revision total knee replacement. So that's been fun. But I also write, and one of the things I have done recently is I do posts, because I get questions from my patients and from other people about what's going on with this virus business. So I do about a post a week on that, because I get friends from all over the world who tell me what's happening. I'm Jazz in Texas, and Luca Marega in Brescia, and I found they had been taken down because they weren't fitting in with what the government was saying. And so I actually published a book which I call the Journal of the Plague Year 2020, because the original Journal of the Plague Year was Daniel Defoe's one in the 1700s about the Black Death. So it's actually been selling very well. And the other thing I do, which is interesting, is I write with my scrub nurse. Because as a guy writing in his own, you get things wrong. But if there's a woman sitting beside you saying, you can't say this, and this is how women would actually think. So Edna Kwame's I met her in Toronto Journal in 1972, and we've been friends ever since, and we've written about 3 books together. So I'm doing that. We just published one right now called Prions from Wuhan, because we know who funded the gain-of-function research for the virus. We know who's funding the research done in Wuhan on anthrax, but we don't know who's funding the research done on prions and why they're doing it. So we thought that might be quite interesting for people to think about.
You certainly do have a lot of varied interest, touching on everything from COVID there. I think even in a surgical circle, we're in an era of super subspecialization. I do implant arthroplasty of the knee and hip, and I don't do scopes, and I don't see feet. And you've touched on foot surgery and implants you've developed, and on scoliosis and a lot of things. So that's interesting to me, and interesting that you've been able to keep such a lot of varied interest open.
Yes, but I mean, as you know, you can't do everything. So for years, I was really just doing hips and knees. I had to stop doing spine, which I quite liked. I mean, I knew, as you're not a spine surgeon, so you probably not know Art Steffi, but Art was the American who developed the plating of spines. And I knew Art, and I knew Ian McNabb, so I introduced him. Art flew up from Cleveland to me, and I took him along to see Ian McNabb. And I did a lot of redo spine surgery, but then you have to subspecialize. You can't do it. So for about 20 years, all I did was artificial hips and knees. I mean, I was one of the original founding members of the American Foot Society, but I stopped doing feet because you can't do everything. And it's only since I stopped operating that I'm redeveloping my interest in these other fields outside of joint replacement.
I think we all benefit from having fertile minds like yours addressing some of these topics. I thank you so much for the conversation here. For surgeons, reps, patients, everybody listening to us on Ortho Real, is there anything you want to leave them with, or anything about your career, or about what we should all be working on, or thoughts?
Yeah, reps get a bad reputation. I worked with drug reps, with technical reps all my life, and I liked the guys. The guys I worked with were honest and straightforward, and if there was a problem, they didn't conceal it. Because concealing a problem is no good at all. You got to tackle it head on. If you think there's a problem, stop now and solve the problem. Have someone look at it, and if necessary, bring in someone from outside to get a new view of it. But I see too much cover up going on right now, and I don't like it. I don't think it's reasonable, and you don't get away with anything in life. I mean, it comes back. You get found out eventually. And so I've always worked very closely with the companies, and I liked it. I found them all great people to work with.
I think that's a great point. I think for surgeons and for the reps we work with and companies, and you've obviously got projects with your scrub nurse when you've got everybody on the team that's got a pure intent and a good goal with what they're doing, it's to everyone's benefit.
Yeah, and the other thing I think is very useful to friends all over the world, that, in latter years, if I thought there was an issue, I could pick up a phone and phone Yunsu Park in Korea or phone Luca Marega in Italy, in Brescia, because these were top-of-the-line guys. And, going to meetings is useful. I mean, we went to Seth Greenwald's Current Concepts once a year for about, I think I was at the second meeting. And so you would be spending a few days with guys like Leo Whiteside and Tony Headley. And, you hash over problems which you can't publish because you're not certain about it yet. But you can certainly talk about it and see if anyone else has any clever ideas. And I think that is enormously useful as a personal contact.
I think you're exactly right, and I've got a handful of people around the country that I trust that I'm very quick to send a text to, and Dr. Whiteside has been gracious about doing some of that as well. So I'll add you to that list, sir, if I can, and hit you up sometime when I need some advice.
Yeah, I've got some of my fellows in England who send me stuff and say, what the hell should I do about this? And, that's your function. I mean, if you've been doing it for 40 years, they may think your idea is crazy, but it gives them a different viewpoint of what to do.
You're exactly right. Thank you so much for joining us. I really do appreciate it, and our audience appreciates having you on the ORTHO REAL Podcast.
Well, thank you very much for asking. I'm honored.